of the leg towards the chest through less than half of the range of motion in hook line. Do you remember hook line? We first prepared our patient to be able to maintain this position, right? So at this stage, the patient should be able to bend the knee, okay, bend the leg to the chest, less than half of the range of motion in hook line. So they may need assistance. I would allow this, no problem. Yes, they may need assistance. The patient would be able also to do facilitated hip extension, so strengthening the leg out in hook line positions. That's stage 2. Okay, based on the patient abilities, we should select the interventions. We should select the exercises. So in stage 1, I said we're going to have the patient placed in proper position, right? So that's the best thing that you could do at stage 1. You may apply E-stem to this patient, yes. You may apply approximation. You may do passive movement at this stage. So your role in the first stage is limited. But talking about stroke, those people, they may pass from the flaccid to the spastic after the first 24 hours. So basically, I'm going to work on them as they are in stage 2 immediately once I see them. Because the first day, the doctor may say that the patient is not stable yet, medically. They may need some more medical care, more than PT at the first day. Okay. And then on the second day of their stay in the hospital, they start PT. So after the 24 hours, making sure that the patient now is medically stable. Don't worry about those things. Okay. So at the stage 2, there is tone. So passive resistance to passive movement. First task. Second, patient is able to bend the knee. Right? So meaning within the center. Okay? The other leg is bent. So the patient is in hook line. Meaning that this patient may be using the associated reactions. Right? The third one, the patient can do some extension at the knee. That's stage 2. So stage 3. Okay, now moving to stage 3. The patient can AD duct or AD duct. The weak leg to neutral in hook line. You may stabilize the foot. Patient can do hip flexion to 90 degrees. If they go with the movement like this way, I would allow it. Because we are still at stage 3. Anything here you could play with, do it. That's stage 3. Stage 4, task 3, the patient can have full active hip knee extension in hook line. The gravity may assist. Okay, I'm good with that. Okay, adduction and internal rotation can be permitted. Those are the symmetry components, right? So the patient now is moving within the symmetry. You remember the title? Well, that's stage 3. Voluntary control, or the patient is able to move within the center. So this is the third task. The fourth task, I'm sorry, not the fourth. Stage 4, the patient is able to do bridging with equal weight bearing, and also the pelvis is aligned. Remember, at stage 4, this when we start the weight bearing for the patient. Okay? Head flexion to 90 degree, then extension synergy. This can be done at this stage. Knee flexion beyond 100 degrees in sitting. You remember when we said the patient can do this movement in sitting? Okay, stage 4, knee flexion beyond 90 degrees. They can do dorsiflexion in this stage 2 with the heel on the floor. Stage 5, extension, then flexion synergy. So they can bend the knee now. So they are able to move within the synergy and getting out of the synergy. They can control that movement back and forth. Flexion and extension and flexion. But we started here in extension because of what? Because the extension is dominant in the lower extremity. So starting with the hard one, and the patient will be able to control the extensors and bend the leg. The patient can do active hip flexion through the inner range. So the thigh clears the seat in sitting. Okay, so all that in sitting. Okay. Hip extension with knee flexion in standing. You remember when I said this movement cannot be accomplished before stage 5, right? So standing with the hip extended and the knee flex. This is typical of a stage 5. Stage 6, lift the foot off the floor 5 times in 5 seconds. Okay. The knee flex 90 degrees. Okay. And each one of them should be equal in amplitude. If you do that for an MS patient, it would never be equal in amplitude. But for stroke patient, it can be done. Full range internal rotation in sitting. Okay. Internal rotations at the knee. So when they are sitting, the leg rotates in and out. And then forward trace the pattern. Okay, doing something on the floor, doing something with that leg. Okay, and then you would see stage 7. We didn't mention stage 7 last time in neuromuscular 1, but actually there is a stage 7. This since 2008. Okay, so we have stage 7, which is the rapid high step movement. Now the patient can move very easy from flexor synergy to extensor synergy to flexor synergy. Moving quickly. So moving quickly means that they are able to control the spasticity there, right? Because the spasticity is going to be increasing with tone, increase the speed of movement, right? But now the patient can control. So now they are reached to the full recovery, okay? That's stage 7. Okay? You can notice that a lot of rapid, quick, again rapid. Okay? So a lot of things that we may promote spasticity, but still the patient can control. So back to stage 2. Usually we have the patient after a stroke, and our focus during the acute stage is to teach them how to do the transfers, bit mobility stuff, trunk control, all these things. Yes, we would do it, okay, but you have a lot of time to work with your patients. And usually the gait training starts with impairment-based interventions. Okay? It doesn't make any sense to have a patient with weakness of the lower extremity and you tell them, okay, let's walk. Right? Weakness is one of those direct impairments after a stroke, right? So it's there. No one can deny that the patient have weakness. If you force your patient to walk without enough strength, means that you are enforcing the negative form of neuroplasticity. We see a lot of patients walking with circumflexion. This is a neuroplasticity, but this is a negative form of it. It's not helping the patient. The patient would not be satisfied with that at all. They're gonna keep coming to therapy looking for better pattern of walking. According to the clinical practice guideline, yes, after 6 months, I know the kinematics will not be changed. Only the speed of walking, the distance can be changed, but do your best at the first 6 months to have those change. Your patient can take up to 6 hours a day of therapy. Currently, we're doing like an hour and a half PT, an hour and a half OT. Maybe in many settings, many acute settings, they do like an hour and a half of PT, okay, a day. And it's every day. You can really use them to help your patient getting strength back of the lower extremity. But the idea is to how to get that. How to get the hamstring facilitated. How to get the hip flexors facilitated. How to strengthen the quad. How to use the position in your side so you could help your patient to stay down and walk better. Okay? So for the lower extremities, what are the group of muscles that you focus on? Which ones I would start with at the beginning? According to those tasks, we're talking about hip flexion. We're talking about the hip and knee extension, right? We're talking about the also dorsiflexors, hip abductors, right? So let's start with the hip.